So I'd like to invite Ling up to the stage, please. Ling is going to give us a talk on a focus on familiar faces. And I'm so glad it's a beautiful way to describe it. I hate the other term. An audit of high intensity users in AED.
I'm Ling. I'm an ED consultant. I work at Lancaster. Thanks very much for having me today. It's actually really exciting to be invited to an event like this because there's so much around A&E and the problems that we are facing at the moment with inequalities and deprivation. To have a whole room full of people who are talking about it is brilliant, and to have yourself from the Well as well, who we've been connecting a lot with through Lancaster, is great. And I think we just need a bit more of this together working, don't we, rather than the silo working that we currently do. I have an interest in public health. I've got a master's in public health, but I'm not an expert in it and by any stretch of the imagination. And I was chairing the RChem, so Royal College of Emergency Medicine, public health group, but I'm now a committee member because I sort of finished my term on it. Not long moved up from London to work in Lancaster, and so this conference has come at a good time for me to sort of just get my head in gear again on this topic. So my presentation, I had relatively short notice for it. It's pretty rough and ready data, so any kind of researchers, academic statisticians in the room, please don't criticise it too much, but also I'm kind of asking, I guess, for help too, because it would be brilliant to have some people on board to kind of support me to look into this a bit further. I've also, sorry, it's a long introduction, changed the title of this because when I wanted to look at the familiar faces data, I realised our ClickSense app from our trust has a glitch. It wasn't working properly. I couldn't rely on the data it was giving me. So I'm going to talk about the familiar faces a little bit, but it wouldn't have been appropriate to talk about it in any great depth because the data was not accurate. So, arrow. Yeah, okay, fine. I think you guys all know that. Probably don't need to talk about that in any detail. This slide is up here just as a kind of, I guess, circle back to the first talk of the morning around the ED attendances. And as we know fully, it's the people who are from the most deprived parts of the population that utilise the ED the most. So I'm just going to be looking back at the previous year's attendances to our ED, so May 23 to April 24. We have 51,000 attendances to the main ED, and we've got an urgent treatment centre connected to that, which sees around 12,000 attendances as well. I'm going to be focusing on the main ED attendances, just again because of ease of analysing the data, but I'll touch on the minor treatment unit as well briefly. So. This is where people come from to our ED all over the country. As you can imagine, most people are visiting the Lake District, and they come to us when they're on holiday. The demographics who present, majority elderly or older, over 65. Sorry, it's not that one. And then the 25 to 54-year-olds, children, and then the 55 to 64-year-olds after that. Kind of even spread of males and females. Ethnicity, so not surprising, the majority is white British, but the next two columns down are not stated or not known, and I think that's a big problem that we have with our data entry. We're not entering ethnicity data, and without that, we are going to struggle to know how to deliver a service in the best way that we can. So a piece of work really amongst our administration staff is actually to improve that data collection, and that's across lots of things we know, not just ethnicity. Okay, so there's quite a useful ClickSense app that we have at the hospital, which can separate out the patients who attend our IED according to deprivation decile. And unsurprisingly, we have more attendances from people who are in decile 1 compared to decile 10. Now, this is not adjusted, I'm afraid, for age or density of population or anything like that. Again, this is where I'm asking for help with it, but I think it still gives you a rough idea of the figures. And we can look at GP practices and who are not, people who aren't registered, and it's about 1% of people who aren't registered with a GP.
Huh? We'll say they are.
Oh, yeah, I'll say they aren't, yeah. So I thought I would just have a look at the deciles and that data in a bit more detail, and just literally look at decile 1 and decile 10, just to see if there was any kind of like comparisons or differences between the two. And if we look at the ages of people presenting in those deciles, so decile 1, the most deprived, is 25 to 54-year-olds, so the kind of people, the age of people who use it more regularly than the over 65s. So whether that's because there are more of that age population in the lower decile, or whether that's because they have multi-morbidities at a younger age and therefore need to use ED more frequently, or whether it's they are using the ED rather than their GPs. These are all questions I don't know the answers to that we need to find out. And the 65-year-olds and the older deciles, we probably assume it's because they're older and they have more comorbidities, as you were talking about earlier. Looking at actual attendance numbers, I said earlier, the numbers are higher in decile 1 compared to decile 10. If you look at the numbers coming by ambulances, there's slightly more in the higher decile, and admissions are higher as well. So, again, we don't know why, but it's possible that the older population in decile 10 is the reason that there's higher admissions, and perhaps distance from the hospital. Immediately around the hospital, in Lancaster and Morecambe, we've got those high priority wards, as we know. People may be able to self-present to the hospital more easily, and the more wealthier areas around Kendal and towards the lakes, they may have more ambulance usage. So I thought I would look at triage category of patients presenting, because often we say that those people who are more deprived use the ED more for lower urgency problems. So the lower triage categories being 4 and 5, so sort of minor things like twisted ankles, falling over, hurting a knee, and then the higher triage categories 1 and 2 down the left side, sort of heart attacks, MIs, seizures, sepsis, those kind of things. And there's a general feeling that people are using the ED for lower acuity things if they're more deprived. So this table is essentially showing that actually the percentage attendances between the deciles for all those acuities seems actually relatively similar. So it's kind of going against what we think about what I've just mentioned around low acuity and higher use. And if we look at the minor treatment unit, because I mentioned earlier I'd left out the minor treatment unit, and that's where most of the lower acuity stuff goes, actually it's a similar thing. There's a similar percentage between the two groups. So are we saying actually that people are using the ED appropriately across all of the population, or are we saying that actually people aren't accessing or GPs or other services equally as well, and they're all having to come to ED to use that? I appreciate, again, this is rough and ready data, and it needs to be looked into in more detail. Don't draw any major conclusions from it, but it's, again, asking for that support to have a look in more detail at this. Okay, so mental health. There's a larger proportion of mental health attendances from decile 1, not unsurprisingly, but interestingly, a much higher proportion of admissions from decile 10. So that could suggest that perhaps the higher income areas are able to access community mental health more easily, and not attending ED with it, but then perhaps come to ED only when they are in extreme crisis and therefore needing admission. And then looking into the high intensity users, higher proportion, of course, using the ED, with more ambulance uses, more admissions, and an increase in our 4-hour standard, which, let's see what probably shouldn't mention politics. Anyway, so ignore anything about that. So, right, I'll just move on to now the familiar faces team. Unfortunately, my colleague wasn't here to be able to just talk about her team herself, so I won't be able to do it justice, but I'm sure most trusts and most hospitals have a team of some sort, but ours at Lancaster is relatively small. It's only a couple of individuals, which has meant that they haven't really been able to audit what they've been doing. So this is the first time I've really just been able to get any data together for them, and they really do need support on that to just show what a good job they're doing within their service. They review their cases each month, communicate with professionals allied to medicine, the well, police, various other individuals, and then produce specific case plans or personalised patient plans for individuals, and they're on our computer system. So they come to the ED, then we can see the best way to address them. So frequent attendance is usually classified as 6 or more attendances in 1 year. The data set I looked at and the ones that the familiar faces concentrate on are 10 or more times in a year, just because 6 more times is just huge numbers and they just can't manage them. So that's the cohort I'm going to focus on, and they had 71 patients in that, and in children 0 to 18 we looked at 6+ attendances in the 12 months. So of the adults, most of the high intensity users are in that middle age group, 26 to 65, a relatively even spread between males and females. This graph is showing the attendances per patient. So up the left-hand side is the number of patients, along the bottom is the number of attendances. So the sort of dot at the far right is up to about 58 attendances by one individual over a year. It's quite a huge number of attendances from one individual, 58, and it's quite a spread up there from 20 up to 58 of a certain number of individuals. So clearly there's a serious impact on the service, and a real sort of importance for us to link up with other professionals to try and reduce that down for him and for the service. Looking at the reasons for attending, won't surprise you to see that mental health is at the top of the list. Then alcohol-related things, learning difficulties, substance misuse, abdominal pain, seizures, and then like a series of more medical complaints further down. And this, if I just remind you, is patients who've presented 10 or more times in a year. If we extend that to 6 or more times, we're probably going to see a lot more other kind of medical causes as well. And actually, it'll be really interesting to see the themes on that, because they may also be areas that we can intervene on to reduce attendance. For example, people come to ED sometimes to get a catheter change, which could be done by a district nurse. That's not a good use of ED. Looking at the deciles again of that cohort, 1 and 2 right at the top, unsurprisingly. And then I just got a couple of my colleagues to have a little bit of a deeper look into some of the risk factors within the adult high-intensity users, and we can see there's significant smoking and alcohol and drug use and unemployment levels, but also a lot of unknown, and whether that's just because we're not looking at the data properly or whether it's because we're not capturing it properly, I don't know, but either of those things are not good, and if this is as much as I can tell from a snapshot, then actually we need to be getting this detail a bit better, so that we can actually inform our service. Okay, just briefly about the children. Majority coming in at age 0 and 1, so 6 in each category. I'm speculating this could be related to health visitor services. I know that's reduced dramatically in the local area. Perhaps the children are using the ED instead of that. There could be a range of first-time parents who are a bit more concerned. The fevers, as we mentioned earlier, could be things like head injuries, which are a reflection, of course, of deprivation too. I'd want to do a deeper dive and find out what the actual causes are, just to understand what's happening. And again, higher deprivation levels, and also social workers for those children. So, summary of what I've been waffling on about is generally that attendances are higher for the lower decile. The acuity does seem to be quite similar across all the triage categories and the deciles. The ambulance usage seems to be higher for decile 10. High intensity users make up a larger portion of decile 1, and there's a lot of presentations related to mental health and substance misuse. And there's a large proportion of 0 to 1-year-olds for peds. So bearing all that in mind, just sort of thinking about where do we go from here, because I think this has created more questions to me than answers, and needing more research and focus on it. The first thing, it would be great to get that app working for the frequent attenders, and on it I will be able to look at complaints and arrival mode and triage category, admissions, length of stay, and more detail around that. Clearly it'd be useful to do a deeper dive into the patients that I've highlighted already today. I think we need to do better inequalities data monitoring. So I've just come along and started looking at this. I'm the first person to do that in my AED. No one's really heard of it. No one's really doing it. So I think we need support to be able to look at this in more detail. And also look at it with more of an inequalities lens. So some of those key conditions that we know are associated with deprivation, have a look at those in particular, see how they're spread across the deciles, and what are we actually doing about it. The Royal College of Emergency Medicine also has audits where we look at time to analgesia, time to critical meds, lots of other things as well. But we don't look at that with an inequalities lens. And I think that would be an interesting kind of angle for us to take as a college. And clearly we need to look at the patient perspective as well and get some qualitative data on that too. Yeah, so that's kind of what I've been saying, really using that. And there's just a few suggestions of things that are ongoing around brief intervention for smoking, sharing information on violence data with the police, and having things like social prescribers and care navigators in the ED. But there's obviously lots of different things that we could potentially do. Right. So thank you. Yeah, sorry, it's quite a rapid run through, but
thank you very much. You've got a bit of time, so do you want to give us maybe a minute on what that team do? Are they case managing those heavier users? Do they sort of provide additional support, liaison with primary care and community support, or what do they do?
Basically that, yeah. So each month they have the list of the patients who are attending the 10 or more times, and then they'll go through each of those and see what the key issues are. And if they're more complex, so they involve mental health and substance misuse, or social challenges, employment or housing, then they'll bring the appropriate people on board, have MDTs with the GP and the patient as well. Yeah. Some of it may be a bit more straightforward, saying, okay, this person, I don't know, some people clearly just come because maybe they're end of life and they're needing to come in frequently because of a pneumonia, in which case that can be addressed in that way. But
I think when they did an audit before, come on to Jane a sec, we had an audit before pandemic on this in Liverpool.
Yeah.
And our practice, I think it was around 300. We won the prize for a patient with the most A&E attendances in a year. It was almost every day.
Okay.
Despite anything anybody did, they just had really high needs, really complex issues.
Yeah, I think that's one of the challenges, is that often these people do have high needs, and you may not be able to reduce the absolute numbers, and as soon as you improve one person, someone else may join it. But I think it's important that we still look at the themes, and there may be ones that are easier to intervene on.
They were managed in a different way within in the emergency department. It was just, they were part of the furniture. So I'm going to ask Jane.
Hello. Really
From
interesting.
behind the flowers?
Behind the flowers. Matches your shirt, actually. Just ask the question. Right, so you've definitely come to the right place for a bit of support around looking at this through an equity lens. I just thought I'd get that in before anybody else. I just wanted to take you back to one of the slides that you had, and you had one of the admissions categories was domestic violence, and what I wasn't really sure about was, are you telling us that there's somebody that's come in with 10 or more incidences of domestic violence, or is that just happens to be one of the categories that people might have turned up with?
Yeah.
Because that sounds quite worrying.
Yeah, no, definitely. And on this data, it is just one of the things that somebody has turned up with. because it's very superficial. No, just...
Turned up more than 10 times, and it just so happens that one of those
Yeah, so...
makes sense.
Yeah, so the attendances, the presentations that people came with out the high intensity users are based on information from my Familiar Faces team to say what the kind of key issues were. So I don't know whether they've come in 10 times with domestic violence issue. I hope not, but there will be an instance where they have come in related to that. And that's exactly a really good question. That's the thing. I was looking at all this, I'm like, I don't really know. And what is it? Is it this or is it that? And we just need to know, don't we? We need to find that out. And if that is happening and it's happening to that individual,
So-
then what's been done about it? Yeah.
Thanks. Okay, there's for one of the attendees online.
All right.
Wondered if you're aware of the project placing a small team of psychologists with an A&E at a Liverpool hospital addressing underlying mental health challenges, which resulted in a marked reduction in people presenting to A&E multiple times, and also offsetting the cost of the psychology team that were brought in to address the mental health challenges for this small group. So they were cost saving, including the cost of providing that service. So maybe something to think about.
Yeah, definitely.
It was Terry that knows about that project, one of our public advisors.
Okay.
Yeah, but the results hopefully are available. Do they stopped it, have they? Anyway, you've got the expert here as well, so I'm just...
It says they're presenting on that Project X, so that's good.
Oh, are you?
So
Right, sorry,
I'll
Pooja.
listen.
Apologies. Hadn't linked the two. So I've got a couple of on this table. So can I start with, a hand went up first with our colleague from who's you want to introduce yourself, because it's an opportunity to do that so people know who you are and which theme you work in.
Yeah, sure. So I'm Andy Pennington, and I am the research fellow for the Improving Population Health theme. I'm a public health and health inequalities researcher from Liverpool. Yeah, I mean, showing kind of the utility of ARC, actually, maybe joining up some of the dots. So, I mean, just today we had Carl Grace before from The Well, which is about helping people who have multiple attendances for alcohol and substance misuse. So it's worth a conversation with him. I mean, there's lots of data analysts, you know, for your age standardisation, and probably because also in your data analysis you want to look at comorbidities and multimorbidities as a cause, and you know, things like the combination of diabetes and mental health might lead to multiple attendances, because attending as a diabetic 10 times to A&E is quite concerning, and you'd think there might be something else going on there really as well. Mark would tell you which data analysis, which theme, probably current health informatics, although if Ben Barr's presented next, he could certainly do it, he's brilliant. Also as well, we heard earlier about the NIHR Insight programme, where they're funding PhDs, so you can maybe even get a PhD student to look at this. So just to reiterate the earlier comment, you have definitely come to the right place.
Yeah, so there's an opportunity for an internship for a member of staff to look at that, including yourself.
Yeah.
As well as it masters the insight, but yes, they would hopefully go on to do a PhD. And finally, and then we're going to move on after to the next presentation. So, would you like to introduce yourself?
Yeah, I'm Dr. Rob MacDonald. I'm an architect and a service user in Liverpool. My question, which I've just thought about, is what is the role of the police in your team? I'm really interested to know what the role of the police is in a medical team.
Yeah, do you mean in the ED department, kind of 24 hours a day, or do you mean as a kind of linking up with, because we certainly link up with the police a lot with the Familiar Faces team, or if there are instances that we need to report to them, or when they bring patients to the ED.
I imagine I go to a hospital in an ambulance and I go into A&E. Am I met by a policeman, a nurse or a doctor? what would happen if I'm met by a policeman? What would be the role of the policeman with regard to me and my well-being in that particular hospital?
No, it's a good question, and I have worked in hospitals where we have a policeman who is in the ED. You're not met by them, but they are in the department around the waiting room and generally keep the department safer, I guess, because people see an officer there, they're less likely to cause disruption. And that was when I was working in London. I haven't experienced it up here. I don't know whether that scheme is still continuing. I think part of it is due to funding and just how many officers there are and if they're available. Instead, we use security, and if there's any issues, security will go, and then we will call the police if we're threatened in any way. And they do come pretty rapidly. But as a personal thing, I guess it would be quite helpful to have a policeman there. Sorry.
Is it common in all hospitals that there is a policeman in the team?
Is it common?
I don't know.
I don't know. I don't think it is common at all. I think we're building relationships with the police as well for data sharing. So, for example, this ISTV thing, which I can't remember what it stands for now, but the Royal College of Emergency Medicine just launched it with the Home Office to basically help with data sharing for violence prevention. So if people attend the ED related to sort of a stabbing or a fight or whatever in a certain area, the police, that data is shared with the police, and then they can focus on that neighbourhood and try and improve the policing in that context.
Just to clarify, that's not naming the individuals for them to be followed up by the police. That's confidential health information. That's about identifying areas where there are problems that may be ballooning out of an incident, rather than these individuals have appeared. I remember, I presume it's still the same, that sort of information is not accessible by the police because there are laws around that. There are a few exceptions, but they are laid out in the law. They don't share confidential medical information with the police force, if that's what you're thinking.
So stabbing, shooting, we would alert the police that we have a victim of stabbing or shooting. It's a bit silly because we're not allowed to say, oh, it's John Smith, but it's about the fact that sometimes people do come back and finish off the job. That's certainly happened in several A&E departments. So from a police point of view and their involvement in A&E departments, some departments might hire a policeman to be around on a Friday, Saturday night. And they tend to be they're not really visible, they're not really patient-facing. It's there if there is trouble, because unfortunately there's a lot of violence in A&E departments for lots of reasons. Right care, right person, which is something the Home Office have brought in and are bringing in up and down the country. Police are withdrawing from mental health support. Now that's got quite a lot of implications because in the emergency department, the powers are not really there. You're fighting on one side the right to life, and on the other side the liberty and the right to make wrong decisions, etc., etc. Now, my opinion is I'd prefer to be in front of a judge and say why I said someone didn't have capacity and why I stopped them leaving, rather than being stood in front of the family and explaining why they left and ended their life. And that's probably me weighing the Article 2 right to life higher than the opposite. But it's very difficult. It's getting to a point with the right care, right person. If somebody runs out of the department, then the police are potentially not going to get involved. And this is from the Home Office. So if you have been recommended a bed for a section 2, so the paperwork hasn't actually been signed because it can't be until there is a place for you to be admitted to. And at the moment, 40% of A&E departments will have somebody waiting at least 5 days for a mental health bed. That's in an A&E department. That's without a bed, without hot meals, without shower, without sunlight, without therapy. You can understand that it will make you angry. So violence isn't usually mental health related. It's usually drug and alcohol related and behavioural related. But if I was that person who was told I can't leave and I haven't got a bed, then actually that might make me unhappy. So that person might run, and then there's a question about whether or not the police will be involved in that to help bring that person back. And there will be times when they won't. And this is a national picture.
Okay, thank you very much. There's a few online comments to just run through. I don't expect to answer them all, but just things that are being raised. So a suggestion around the qualitative information you might ask from our attendees. Why did you attend? And if this other service was available instead, might that be something you'd have found more useful? Particularly your mental health. All health and care needs to be psychologically informed. Another question, in one of your data sets, everybody was white. Did you not interview any BAME communities?
I haven't interviewed, it wasn't
and that's their word, not mine.
Oh yeah, it wasn't none of it is qualitative, so I haven't
Yeah,
interviewed
so I thought
anyone.
it
It
was
was just
quantitative, yeah.
demographics off the computer system.
Yeah, so this is the demographics from the system, so
Yeah.
that's the answer to that person. That's what I was thinking. We shouldn't expect a higher number of white admissions to the emergency department. People of colour face multiple barriers accessing appropriate healthcare. There are huge inequalities here. The pandemic really brought this into the spotlight. That's a statement rather than a question, I guess.
Yeah.
And another statement here, all police officers who are part of a multidisciplinary team and EDs need to be trained in trauma-informed approaches. I'm sure that's true, and I'm sure that they are, or I would expect that they would be, if that's something that they're doing regularly. So I guess you don't need to answer those. They're just pointed to being made and things to bear in mind coming from the audience online.
Definitely. And just to touch on the ethnicity thing, I completely agree. And that was one of the challenges that I mentioned, is that after white British, it was just not known, not stated. So we don't know the clear picture, and we are...
I wonder
creating
if it's actually about
inequality.
training of the staff who were asking the question, and whether they are not sort of reassuring enough as to why the question's being asked.
Yeah.
I suspect there are lots of sensitivities for people who don't consider themselves to be white British, how they answer the question and why they're being asked, and it might be that those data aren't being collected. And I think when we've looked at that in general practice, there's big gaps, and it's how people self-identify anyway, and I guess there may be an issue to address with your team. Fantastic, thank you very much once again.
Thank you.